It says rotate your phone. All right.
We're live? All right. Hello. Thanks for joining us. We are having our first, hopefully first of many Q&As with some experts in various fields surrounding myasthenia gravis. I'm Alesheia with the Myasthenia Gravis Foundation of Michigan, and today we are with several of our board members, actually. We have Dr. Glisson, Dr. Amit Sachdev, and Cassie Bos, who is with Briova Home Infusion. And we're going to do a Q&A on the IVIg shortage that is happening right now throughout the country, from what I understand. So without any further delay, for those of you who are tuned in, feel free to type questions. Not sure how quickly we'll be able to get to them. We might have to address them afterward. But if you'd like to ask anything of our expert panel here, feel free to do so while we're broadcasting. So hello, and thanks for joining us today. So why, can any of you answer, is this IVIg shortage happening in the first place?
I can take that one. So there are a lot of different variables at play when it comes to the supply of immune globulin. But what we can say definitively right now is that the demand is definitely outmatching the supply. And ultimately that's going to result in certain manufacturers being unable to fulfill their contractual obligations with certain buyers. So it's not affecting everyone. It's on a case-by-case basis, but it's definitely due to, the demand outmatching the current supply.
Okay. Is there any end to this shortage in sight?
So,
Cassie's got this one too.
So that's very difficult to know because it's a fluid situation, and I don't think that's definitively something that anyone could know. But based on when it began and how long we know that it takes to manufacture immune globulin medications, I think it's safe to say that it will continue throughout the rest of 2019 and possibly longer. But again, that's something that no one can know definitively.
Okay. Is this something that patients should be like a call to action to their loved ones to go donate plasma and try and get this shortage cut even shorter, or is that not something that could affect that at all? Or we're not sure.
Yeah, we don't believe that the reason for the shortage is due to a lack of plasma donors. However, it is always a good idea to encourage your loved ones to donate plasma. We never can get enough of that, so I think that's always helpful.
Okay, thank you. What sites of care are being affected by the IVIg shortage?
So I can take this one. That's all right.
Perfect.
Yeah. So most patients will get IVIg either at an infusion center or at their home. While again the shortage is patchy and different providers have different supplies, our experience as a practice has been that the infusion centers have had a little bit harder time maintaining supply. Again, it's very case by case and person by person. Ultimately, your infusion provider will be able to tell you what their situation is.
Okay, thank you. Did you have any? No? Okay. Are all of the ingredients in all IVIg meds the same? Like, is it going to affect a patient if they're asked to switch meds, or are they not going to notice any difference?
I can take this one as well if you don't mind.
Sure, then I can offer some
Sure.
thoughts too.
So different IVIg products are mixed in different solvents. So that's what the drug is dissolved in. And there are different side effect profiles that you might see with those products. For example, some products are mixed with sugar in the bag. And so it may not be appropriate for a diabetic patient to have that particular formula. Again, this is very patient specific, and it's very infusion center specific as to who has what.
So I would agree with that. I think more than likely the ingredients in the formulation being generally the same will probably mean that the efficacy may be the same or similar from product to product, but there are individual variables, and I certainly have seen individual patients who've responded or tolerated one formulation better than another. So I think it's very difficult to predict, and it really is a case-by-case basis.
Okay. And if that were something of concern to a patient, who is the right person for them to go to with that concern? Would it be the doctor prescribing the IVIg? Would it be their pharmacist? Or who should they go to if that's a question that they have or a concern that they want to address?
It should probably be their prescribing physician.
Okay.
And certainly I think we try to maintain a good dialogue and a relationship with the pharmacies so that we can bring those concerns forward and address them in areas where we might not have direct knowledge or expertise.
Okay. And I imagine some of that too, it's very important for the patient to advocate for themselves and be the ones to say, I noticed a difference in this med, did it change, or what is different about it? And if you guys don't know anything's wrong, then of course you wouldn't know that anything needed to be addressed in the first place, right?
Mm-hmm.
So patient advocacy and be your own advocate. Excellent. So what should I do if I'm the patient being told that my infusions are going to be delayed or that my dosage is going to be reduced?
Let your provider know. So your provider is your partner. They're the ones who have prescribed the drug in the first place. And they'll let you know if they feel like a dose reduction is appropriate or if spacing the drug is appropriate. It's, again, very patient specific.
I think part of it is just having knowledge and awareness that this is really a national shortage. This isn't something that is particular to your doctor's office or your pharmacy or your community even. So I think it's important to know that this is a general problem and not to feel singled out or as if your therapy is being modified for any particular personal reason. And then I think also just to talk with your prescribing physician to consider the variables that might impact whether or not this is going to affect you negatively or not. How long you've been stable on a certain medication, if you've had lapses in therapy before, how much or how little have your symptoms recurred. Those are all important things to consider as we all think through together the right way to respond to this shortage and keep our patients safe.
Mm-hmm. Thank you.
I would add also, I think it's fair to say that, you could consult with your prescribing physician about possibly considering a change for the site of care to see if there may be another site of care that has the medication that you need available. And I think physicians have primarily been on top of knowing where that may be for you.
Could you elaborate on that a little? Meaning like if a patient is used to receiving their infusion at an infusion center, but they're being told that the center doesn't have their drug available and they're not maybe sure when it's going to come back, what would their options be if that patient really says, nope, I can't wait indefinitely, I want this now, what can I do?
So I think just like Dr. Sachdev said, most patients are either getting their infusions in an infusion suite or at home. And it's safe to say that many of the national home infusion companies and specialty pharmacies have been maybe less affected by the shortage than some of the local sites. So that may be appropriate to discuss with your physician and see if a change in that direction could assist you.
Okay.
Unfortunately, sometimes this gets a little complicated. Insurance companies get involved, and where is an authorized site for that insurance company? In our office, we have moved patients from hospital-based infusion center to a different hospital-based infusion center. Again, it's all about who has access to what. And unfortunately, there's probably not a one-size-fits-all solution.
Mm-hmm.
Well, and I think the other part too is, as we learned earlier, this being a very fluid situation, it could change day to day or week to week. So just continuing to speak with your provider in the office about how this dynamic environment is changing and how we can respond in real time.
What will happen good question for the doctors here. If my infusion is delayed, or if I have a reduced dose, are my symptoms going to escalate? Do I need to anticipate my disease being worse during this shortage, or do I have nothing to worry about?
So it is, again, a hard question to answer. It's very patient specific. Certainly, I'm sure Dr. Glisson and I both have patients who are very dependent on the timing of their IVIg and who start to feel the wear-off effects even before the next dose is due. We have other patients who we're actively thinking about spacing or discontinuing the drug anyways. And so ultimately, the question is very patient specific. How sensitive are you towards the end of your dose cycle? And what are your major features of the disease? You know, is it that your eyelids start to droop? Is it that you start to have swallowing difficulty? And using those features as a metric for, is my disease recurring or not?
So to some degree, it's, as you've been saying, it's individual and balancing quality of life versus whatever else you're trying to balance throughout this particular part of our own care.
And again, it might be useful if you are an individual who is faced with the possibility of further spacing out your dose or a lower dose, just to ask to see your physician sooner than you might, and so they can examine you and talk with you and look for subtle features to help get a sense of whether or not things are stable or whether symptoms might be recurring.
Mm-hmm. That's a great suggestion, and I wonder too, how useful are things like patient portals that are available now throughout a lot of health systems? Is that a really convenient way that you found as a practitioner for patients to be able to reach out to you in a quick and efficient manner to log on their patient portal, email Dr. Glisson and say, hey, I feel like my eyelids have been a little droopy, I'm 3 weeks late on my IVIg, like what do you think? Is that a good thing, or is it better for them to call the office and try to talk to a nurse? Or
I think both are valuable. One of the things that I really appreciate with the patient portals is the ability to send photos and even videos in a secure fashion. And so for someone like me who's looking at eyelids or eye movements, oftentimes it's a little difficult to quantify or describe that in a portal message. But if they can send me a photograph or even a video, it's very, very helpful for me to be able to assess how they're doing.
that's great. Yeah, and for patients out of town, that saves a trip into the city or wherever they might be coming from. Yeah. So how can we advocate for ourselves as patients during this shortage? I think this might be an interesting question for all three of you from your different perspectives. Maybe start with Cassie. From your perspective, how can patients best advocate for themselves during the IG shortage?
I think one thing is important to maybe help educate if you are going to an infusion suite or wherever it may be, if they've indicated that you may not get your dose on time or that you may receive a reduced dose, just to help educate them about MG. I don't think it's safe to assume that everybody is familiar with it. So that's probably a good first step. I would reach out to your physician and also engage with the MG Foundation. Reach out to the office. We're here to help. We've got resources available who can help advocate for you as well.
Absolutely.
I would say know your disease. So if you have a disease that involves shortness of breath, swallowing difficulties, these are reasons people go into the hospital. If you have a disease that's very dependent on the timing of your IVIg, if you know these things about you, being proactive about making the phone calls ahead of time and seeking additional treatment options is going to be important. Being able to measure more subtle features, drooping of the eyelids, endurance with the arms, climbing stairs, how long does it take you to get short of breath climbing stairs. These are important subtle features that the disease is getting worse, and important enough that often your physician might make a treatment decision, or at least engage with you in a conversation.
We had a question from the audience that's watching. The question was, I've noticed that more rural areas are having harder time supplying IG. Is there a reason why some sites get more than others?
That's a great question. Cassie, would you know a
So I don't know that it's necessarily, rural versus more populated area, but in general, what we've seen is the more resilient sites of care are the ones where they have multiple contracts. So maybe they're not just contracted with, GammaGuard or Privigen, maybe they're contracted with more than one medication. So it's possible that the sites where we're seeing that happen more often may have just a single contract. I think there's probably also some reason to believe that the contracts that may not be able to be fulfilled, they are going to be maybe the ones that have smaller volume contracts. So it's if a manufacturer can't supply every contract that they are committed to, I think it's reasonable that they would be supplying the larger contracts due to the number of patients that would be affected by shorting a larger distributor.
Okay.
So if it is a more rural area, they may have low volume, and that may be why they could be seeing the shortage happen to them a little bit more heavily than in some of the more populated areas.
Okay. I would like to revisit the previous question because I think that Dr. Glisson was going to share something, and then I segued into something else really quickly. Would you like to head back to how can we advocate for ourselves during the IV shortage?
Sure. Well, I think, again, one of the most important things is just to have knowledge about what this shortage is and what it represents. So undoubtedly, when there's a question about the availability of medication that you rely on to keep your condition stable, it's going to be very frustrating and probably even very frightening. And so I think just having knowledge that this isn't something that is being driven by your physician or your doctor's office or your infusion center or your insurance company, this is really a national shortage that we're all working with. And we all know that feeling frustrated and stress and other things can actually make your condition worse as well. And so just relying on the partnership that you have with your physician and with your physician's office to figure out ways to work through it together and figure out options, because there are options.
Mm-hmm.
A follow-up question, is one brand of IG more available than another, such as GammaGuard or Privigen?
I think you kind of touched on that by saying that kind of depends on the contracts that the different companies, the providing companies have with the pharmaceutical companies offering the drug.
Yes, yeah, that's definitely a factor. According to the FDA, as of yesterday when I checked the website, GammaGuard is listed as a shortage drug, so you may see that happening more often. But it is such a fluid situation because that we're short, and then what we've seen is it kind of bounces back and forth. So it changes so frequently. But as of yesterday with the FDA, GammaGuard was listed as one of the drugs being affected by the shortage.
Did that, sorry, I'm like trying to think what that question fully was. It was just saying, is one brand more short than the other? And that's kind of a back and forth volley, it sounds like. So, I'm short on my IVIg. I've been late on it. I'm getting small doses. Should I take more of my other meds to try and help counteract the fact that I'm not getting as much IVIg?
I would seek care. So if you're concerned that your disease is not well managed or your symptoms are recurring, and the treatment plan that had been laid out between you and your provider may not be executed the way that it was hoped to be, rather than taking things into your own hands, I would say seek care. Potentially in an emergency department situation if that is required. It's important. We do take some of these medicines for granted. Many of our patients have decades of experience with these medicines. Still, they can hurt you. And so getting some guidance, I think, is the appropriate next step.
It's absolutely essential, and as anyone who has a history with MG will know, we manage symptoms with any medication within a therapeutic window. So you can have symptoms if you have too little medication, and symptoms if you have too much medication. So more is not necessarily better, and in a number of cases can actually make things precipitously worse. So I agree with Dr. Sachdev. This is something that you really want to coordinate with your physician.
Okay. So if I go to the ER in an MG crisis, is the hospital going to have IVIg to give me, or am I going to be totally out of luck during this shortage?
So our center manages actively about 130 patients with myasthenia gravis annually. That means that we have 2 or 3 patients in the hospital at any given time. We have not seen statewide any inpatient shortages. Does that mean it can't happen? No, it doesn't mean that at all. The hospitals, as far as I can see, have been fairly heroic in their attempting to coordinate inpatient care. And so I would head to the closest hospital if you feel that you're having a medical emergency.
Mm-hmm. Good. I'd feel good about hearing that on the patient end, that at least my emergency care is hopefully going to be covered. And I understand an MG emergency care in and of itself, without an IV shortage, IG shortage, can be quite a bear to navigate. And so maybe that is a topic for a future discussion on how we can really actively handle our own emergency situations in a way that's good for the MG, because I know that there's some nuances to that.
Here's a good follow-up question also is somebody noticed that Medicare patients seem to be having a hardest hit. They are not approved for home infusion that she has noticed and that seem to be infected more.
Okay.
Any experience with that?
So we, when it comes to Medicare and Medicaid, certainly for home infusion, you do have to meet certain criteria. You have to be homebound, essentially, for many cases. We have been successful in making that argument for some of our patients that their disease is progressing. So we have had patients who do have Medicare and Medicaid transition to home infusion if needed, and we were able to navigate that.
Yeah, I can chime in on that too, just with how it bills. So for Medicare, with home IVIg at least, any neurological diagnosis is going to have to be billed through the Part D plan, which is the drug plan. And that is a little bit different than how it bills when you go to an outpatient infusion center. If it's outpatient, it's going to go through Part B, like Bravo. So it's billed differently, but it is still covered. So there are plenty of options out there. And I don't believe that Medicare patients are being inadvertently shorted above other patients. I have not seen that personally at all. I think nobody wants to see any patient go without their medication, and I have not seen it on a patient-by-patient basis where they've been, shorting certain payers like Medicare.
Mm-hmm.
So, yeah.
Now with that switch between how it's being billed to Medicare, does that mean that where patients who are maybe receiving their infusion at an infusion center were not seeing any out-of-pocket cost, but when they switch to home infusion, they possibly are seeing that they have to pay, and maybe that's one of the reasons why some of it is hard for patients?
Yeah, I think it's that's treated on a case-by-case basis. Yeah.
I imagine same with any. Okay. Yeah. So what happens if my infusion center tells me that I'm a low priority patient? How can I make them understand or hear me when I try to explain my MG a little bit better and explain why that might make me a higher priority patient than they think I am?
That's a tough conversation. Ultimately that center would have made that decision out of some rationale. You hope that would have been made at a medical director level or something similar. So it's really hard to understand why that decision would have been made. And it could be business, it could be logistics, it could be the patient population at that particular center. Certainly if you are inclined to attempt to educate the staff that you interact with, that's probably okay. I wouldn't get belligerent. I would advise against that. But it's just such a tough question to figure out the rationale.
Mm-hmm. I imagine some of that comes back to, once again, being your own advocate and keeping that good line of communication with your practitioner open. Because again, if you don't know that I'm struggling, then you're not going to know that I need to be a priority patient. And also, if you don't know that it's really important to me, and that the fact that it's important to me feeds into it being a big deal to me, then of course that isn't going to be handled that way, right? And so that's part of keeping up on our appointments, keeping good open lines of communication, and being friends while we're also practitioner-patient. So I've exhausted all of my options for IVIg, and or I've heard that I could maybe get subcutaneous IG. What is that? What is subcutaneous IG, and how could I learn about possibly switching to that if that interests me?
That one's all yours.
All right. So subcutaneous IG is administering immunoglobulin into the skin, most commonly right underneath the belly. Subcutaneous IG is administered at the home, and it is done by the patient. So usually there's some training involved, but ultimately the patient administers their own drug. It's important to understand that the Food and Drug Administration has not approved any formulation of subcutaneous IG for use in myasthenia gravis. The subcutaneous IG is approved for use in primary immune deficiency and a nerve disorder, CIDP, but it is not approved for myasthenia gravis. What that practically means is that we just don't have the data to understand how well this version of IG treats myasthenia. And we don't have the safety data to understand how might it interact with the disease. Finally, it means that on a practical sense, there are concerns about whether or not insurance companies would cover it because it's not approved. So I'm not sure that subcutaneous IG is a practical option for many patients with myasthenia. We just don't know if it works right, if it causes side effects, or if it's even accessible.
And so it's certainly not a seamless transition. If we're struggling getting the IV version, it's not just a quick phone call to switch to the subcutaneous. It's
Correct.
Yeah, okay. Thank you. So we already have touched on this. Which brands of IVIg are being affected? Is every type of IVIg, or are there specific brands that are being affected more than others?
Yeah, as of yesterday, GammaGuard is affected by the IVIg shortage, and according to the FDA, and then also Cuvitru when it comes to subcutaneous. But again, like Dr. Sachdev said, I don't know how many of our MG patients are going to be affected by the subcutaneous shortage. So it's changing on a very frequent basis, but that's where we're at with the FDA website as of right now.
Okay. Well, and there are many, many brands, correct? There are both name brands and generic, and so it's some of that is, again...
There's actually no generic.
There's no generic.
No.
Everything's name brand. Okay,
Yes,
interesting. But then that's also part of your conversation with your provider. If you're concerned about what you're maybe being switched to versus what you were used to taking, and will be handled case by case and concern by concern, it sounds like. Excellent. Are there any other things that you would like to add for our patient group that are watching us tonight?
I think it's important that you communicate with your provider. I think we've harped on that a couple times. If you're concerned about your disease, say something. If you're concerned about your disease, try to track it in some way. Don't go overboard, but understand, how is this disease affecting you? If you're not sure if a particular symptom is attributable to the disease, bring it up. You have to be you have to be cautious, and you have to advocate for yourself, because this disease can put you in the hospital.
Do you have,
I would agree with that, and I would just also again emphasize the fact that if you have concerns, you're certainly not alone. There are people who are able to help, and there are other options that could be considered to help work through this shortage, partnering together with your physician.
Very much. As Cassie mentioned, those of us hanging out in the office at the Myasthenia Gravis Foundation of Michigan are always here to help you. Those of you who know Esther know that you're always going to get some wonderful help from her if you have any questions. And of course, if you contact us here via the Facebook page or via our website, particularly if it's a question that you'd like to ask a doctor, if not your doctor, we can always send it toward one of these two gentlemen or some of our other medical advisory board members. If they're not your personal physician, of course, they can't necessarily give you any advice specific to you. That's something you should always do with your physician, if that's what I've learned today. But we can always help field your questions here at MGMI as well, and help alleviate any of your concerns. Anything else that we might be able to touch on, or did we cover all of our key stuff for IVI shortage today? IVIg? Excellent, excellent. Well, once again, I would like to thank Dr. Chris Glisson, Dr. Amit Sachdev, and Cassie Bos of Riova Home Infusion for their time today to teach us a little bit more about the current shortage of IVIg here nationwide. For those of you with more questions, feel free to post them there on the Facebook page. We'll send them to the right people. Send us a message. mg-mi.org is our webpage. Thank you for tuning in today, and hopefully we'll see you soon with some more good info.